friends and colleagues, time is marching on and prayer time is approaching, so we will move along. I introduce the first speaker of this session, and it's Professor Giorgio Zanchi, past President of the International Society for the History of Medicine and Director of Neuroscience at the University of Padua's Medical School. And he will be talking about the influence of Islamic culture at the dawn of the Padua School of Medicine.
Thank you, Dr. Brennan. First of all, I wish to thank the organizing and the scientific committees, and especially the Dean of the Faculty, Professor Sidi Adil Ibrahimi, and Professor El Bahir Benjeloun, General Secretary of the Heritage Committee. Because the cable is too short for my presentation. Dear colleagues, distinguished guests and friends, ladies and gentlemen, all of the historians agree on the extraordinary role played by the Padua University on the development of medical knowledge. On this presentation, I will consider its main contribution to the fundament of modern medicine. As you know, Padua was the state university of the Republic of Venice. On this presentation, we consider its main contribution to the fundaments of modern medicine. Here we see the portraits of some of the most prominent researchers that during the century illustrated our university. We see Alessandro Benedetti, Andrea Vesalio, Realdo Colombo, Gabriele Falloppia, Fabrici d'Acquapendente, William Harvey, Bernardino Ramazzini, and finally Giovan Battista Morgagni. We will talk a little bit on some of them. So the first goal is to summarize the main contribution of this university to the fundamentals of modern medicine. And the second point will be to consider the philosophical attitude behind these advancements. With the Venetian expansion of 1405, Padua became the site of the State University of the St. Mark's Republic and gave its main contribution to advancement of medicine. We will briefly outline some of this character, as I said. In Padua, studies had assumed a philosophical direction that emphasized the empiristic content of the biological works of Aristotle and favored, as a result, the observation of nature, an essential aspect of the revival of the anatomical investigation. In this background was situated the activity of the Preveselian anatomists in Padua, and in particular the teaching of Alessandro Benedetti, who, at the end of the 14th century, advocated the necessity of dissection in his book, Anatomice, of the direct observation of the human body in the formation of the physician. Here we see a quotation from his book, "I urge everyone, both apprentices and physicians or surgeons, to visit such a theater, which should be attended with solemnity at least once a year, because it is there that we contemplate the things from life." On a practical level, he realized the construction of a dismountable anatomical theater aimed to an improved instruction based precisely upon objectivity. This was the cultural climate that surrounded a young Flemish, Andreas Vesalius, upon his arrival in Padua. It was during the 5 fruitful years spent as a professor of surgery and anatomy at the same University of Padua, where he graduated in medicine, that the De Humani Corporis Fabrica was realized. Published in 1543, this work is unanimously considered the fundament of modern medical research. As we can see from in the frontispiece, Vesalius worked alone at the dissecting table. You see that the professor steps down from the chair and put his own hands in the cadaver. The 3 individuals, lector, dissector, and ostensor, taking part in the traditional demonstration of galenic anatomy, as we can see from this picture from an incunabulum of the end of the 14th century, disappeared. These 3 characters disappeared, and the professor stepped down from the chair to perform directly the dissection of the body. The original character of Vesalius' teaching arose from the fusion of Homo sapiens and Homo faber into a single investigator. This is a typical Renaissance concept. Not only the intellectual power is important for the mankind, but also the so-called manum munus, the gift of the hands. So Homo sapiens and Homo faber. In this revolutionary book, the dissected cadavers are illustrated according to the ideals of Renaissance beauty, with regard to the principles set forth by the Venetian school of Titian. Doubtless, the illustration of the brain, that as a neurologist of my specific interest, are extraordinarily realistic, possessing a naturalism that was previously unknown, as we can clearly see by comparing a selection of them with the representation of this organ given by Berengario da Carpi only 20 years before. We see on the right the brain as represented in the Fabrica, and the brain as represented, the best representation of the brain before that of the Fabrica, by Berengario da Carpi, just 20 years before. You can notice a strong difference in the realistic reproduction. The way had been paved. After Vesalius, Columbus followed, who first described the small circulation after Ibn Nafis, of course, but he was not, he didn't know, of course, the work of Ibn Nafis. It was an independent discovery. And later Fallopius, who gave outstanding contributions to the knowledge of the female reproductive system, tubae fallopii, and to the knowledge of cranial nerves. This time is really the golden era of the University of Padua School of Medicine, as is documented even today. If you come to Padua, as Professor al-Bashir did recently, we visited many places of Padua University together, you can see many coat of arms. In fact, more than 3,000 are still on the walls of our university, and they represented the coat of arms from all over Europe, from Scandinavia to Spain, from England to Greece. It is the golden era of Padua Medical School, attended by many foreign students who here converge from all over the European countries, and pour cause. In fact, in the same year when Vesalius' De Humani Corporis Fabrica is published, Da Monte introduces for the first time the method of clinical instruction at the bedside at the Hospital of San Francesco Grande. The critical attitude of the anatomist is transferred to the physician in this way, teaching at the bedside of the sick. We pass from the research to the applied research, to the clinical side. In this century, Padua reaches an indisputable supremacy documented by such events as the institution of a true scientific vanguard structure on the cutting edge, the first university botanical garden, Hortus Simplicum, and the first permanent anatomical theatre. Established in 1445, the botanical garden allows the ostensium simplicum, that is the demonstration of the real plants, developed from the lectura simplicum, that is the mere literary description of the subject. So we pass from theory, from the book, to the real thing, to the demonstration of the true plant. This is the reason why this called today Orthobotanicum, but the true name was Hortus Simplicum. It is devoted to the growth of the medical plants, is established for that purpose. Erected in 1594 by Fabrici d'Acquapendente, the anatomical theatre is the material expression of the Paduan anatomical tradition at its apex. It became the model of the demonstrative teaching of anatomy in various European universities. So that similar structures were to be erected by pupils coming back from medical studies in Padua in such universities as Leiden, that we see here, Copenhagen, Basel, Uppsala. Among the other great accomplishments of Fabrici, we remember the description of the Venus valves and the collection of colored anatomical paintings which he left in his testament to the Venetian state. For this anatomical atlas, Fabrici is recognized as the first to sense the importance of colored illustrations for anatomical preparation. This is a very, very important point, because besides the artistic value, these pictures are real expression of the aim of the Padua Renaissance Medical School for the realism, the objectivity. In those days it was impossible to get a colored print. So the only way to add the only missing point, we had already the perspective, we had already the possibility to give the idea of the dimension with the copper engravings, but the color was missing. So Fabrici d'Acquapendente had prepared these paintings, which are unique, in order to get the last element which would put closer to the reality, the anatomical reproduction. Fabrici was also the teacher of William Harvey, the discoverer of blood circulation. We remember that booklet, the Esercitazio Anatomica de Motu Cordis Sanguinis, a very tiny one, published in 1628, but one of the most important books in the history of medicine. Attracted to Padua by the reputation of its university, the young Harvey got here his degree in medicine in 1602. After returning to England in 1628, as I said, he published his outstanding contribution that is recognized as directly connected with his Paduan education, since here he learned of the existence of the valves of the veins from Fabrici and of the quantitative method from Galileo. These are the two pillars of the Harvey's discoverer of blood circulation. The existence of a unidirectional organ that would really would contrast with the Galenic hypothesis of the blood of movement considered to be like a tide, and also the quantitative method that would not explain how so much amount of blood expelled in the unity of time from the blood would be consumed and how it would be produced. It should circulate. Dear colleagues, in the Taming of the Shrew, William Shakespeare has one of his characters to express for the great desire I had to see fair Padua, nursery of arts, and I am arrived, and I am to Padua come, as it hath leaves a shallow splash, to plunge him in the deep, and with satiety seeks to quench his thirst, his scientific thirst, like Vesalius did. We can say, because this is Shakespeare said this because in those days Padua was considered the prominent European center for medical studies. We can say that the University of Padua became nursery of arts, of course arts intended in the ancient way, not only from an artistic point of view, but as a research, human realization, technical realization. We can say the University of Padua became a nursery of arts thanks to its tradition of free research. But let's go back now to the roots of this outstanding accomplishment. The decline of the Roman Empire and the establishment of a dichotomy between the terrestrial and the celestial world, and between the body and the soul, started a downfall in the interest for the observation of nature. Gradually, after the year 1000, different factors contributed to a new attention focused upon the physical world. A relevant cultural event was the rediscovery in the Western world of numerous classical books. In particular, the knowledge of the so-called physical writings of Aristotle revived interest in the study of nature, opposed to themes centered on afterlife. In his poem, La Divina Commedia, Dante Alighieri quotes Avicenna and Averroes, this latter as the author who wrote the vast commentary, fundamental for rediscovering Aristotle. This is an authoritative evidence about the importance recognized already in Middle Age to the pivotal role of Arab thinkers in the renaissance of Aristotelian philosophy. Evidence of Muslim influence in the University of Padua can be argued looking to this engraving of the well-known inculabulum Fasciculo de Medicina, printed in 1494. The majority of the volumes there represented bears the name of Arab authors, among them Rhazes, Mesue, Avicenna, Averroes. I edited a monography on the manuscript Fanzago. This is a further document on the Arab influence of the University of Padua. I edited a monography on the manuscript Fanzago of Padua School Medical Library. Dating back to the late 14th century, this manuscript deals with cauterization, ancient therapy reported in vogue by the Islamic scholarship. We had also this morning our colleague Maria Blanca Viesca referring to the cauterization used by Albucasis, and yesterday some other speakers quoted this kind of therapy. Moreover, we have to remember that for centuries the canon of medicine of Avicenna was among the textbooks studied in Padua, as in many European universities. But let's go to the core of the influence, Arabic influence, Islamic influence on the dawn of Padua University. In Padua University, a relevant Muslim influence can be traced back to the end of the 13th century, so to the very beginning of the medical school, to Pietro d'Abano, an icon character who is considered the father of the Padua Medical School. Physician and philosopher, he had stayed in Constantinople to directly study the medical works of classical antiquity. He also visited Paris, where he taught medicine with resounding success. According to him, the object of the researcher is to unfold the natural phenomena in a natural way, in naturalibus naturaliter, without recurring to direct divine intervention. As an expression of this renewed interest for the nature, throughout the course of the 1300s, the dissection of the human body began to be performed in the northeast of Italy. In Padua, Pietro d'Abano himself performed the first local dissection. It was carried on a body of a pharmacist who was deceased for having ingested a mercury. So it was a first forensic autopsy, we call it today. Some scholars deem that Pietro d'Abano, whose principal work Conciliator Controversiarum quae inter philosophos et medicos versantur attempts to converge abstract reasoning and empirical observation, brought with him to Padua the thought that followed Aristotle's teaching as interpreted by the Arab philosopher Averroes. Said line of thought, named after him as Averroism, announced that the doctrine of double truth, which, by stating the separation between faith and data obtaining from the study of nature, allowed the believer to overcome the apparent contradiction between the revealed word and scientific knowledge, and therefore protected the freedom of investigation. In conclusion, Averroism seems to have been one of the foundations of freedom of thought, at the origins of the outstanding accomplishments of the medical school of Padua, expressed in the motto Universa Universas Patavina Libertas. Paduan freedom of thought for everybody, everywhere, which identifies this university in the course of its history. Thank you very much for your kind attention.
We will take questions later, but we would like to move on now to Professor Beth Barron, who is past president of the Middle East Studies Association of North America, director of Middle East and Middle Eastern American Center at City University of New York, and she will be speaking of the Egyptian doctor Naguib Pasha Mahfouz, father of obstetrics and gynecology.
I'll get started while they fix that. Yeah, it's very hard to talk about another doctor after Zahrawi, who's obviously has a large footprint. I'd like to make... This is the next one? Is this it? Okay. I'd like to sort of make two interventions in the conference. Well, the first one, before making the interventions, they're suggesting is to thank the organizers for the invitation and for the wonderful arrangements. The first intervention I'd like to make is we've been focusing on the Golden Age, and I'd like to urge students and colleagues to think more about not skipping over the colonial period. The colonial period is not just a period of decline, but it's a period in which we have engagement of engaging in resisting colonial powers, and it's essential to understanding where medicine is at today. So the story I'm going to be telling about Dr. Naguib Mahfouz, who, to get to the chase, delivered the author, Naguib Mahfouz, who is named after him. That's part of the story. Is part of this colonial story. The other intervention I think I'd like to make is to suggest that we bring patients into our stories. I'm a social historian by training, not someone who came out of history of medicine. So this is the technique. In 1902, when he was still in medical school, Dr. Naguib Mahfouz, who was born in 1882 and died in 1974, was sent to Alexandria, where one evening Dr. Shukri, assistant director of the government hospital, asked him to come to his private clinic to assist in a difficult labor. Shukri had tried unsuccessfully to deliver the baby with forceps and without anesthesia, but the baby would not budge. He asked Mahfouz, who had thin arms and hands, to try to bring a foot through the cervix, but Mahfouz, who had never seen a difficult delivery labor, let alone a normal one, declined. Mahfouz gave the patient anesthesia and reassured her, and the doctor and his assistant attempted to pull the fetus down for 2 hours. The body came out, but in the process, its head was severed and remained in the uterus. When Mahfouz suggested that they call in an obstetric surgeon or take the patient to a government hospital, Shukri told him that there was no foreign or Egyptian obstetrician in Alexandria. After subsequently learning that the woman died overnight, images from the incident haunted Mahfouz, who writes in his memoirs that from that moment he decided to do everything in his power to study obstetrics and gynecology and to dedicate his life to helping women suffering from difficult labor. After taking his exams, Mahfouz established an outpatient clinic for obstetrical and gynecological patients at Asr al-Aini, the government hospital in Cairo attached to the School of Medicine. He delivered thousands of babies in normal and difficult deliveries in government and private hospitals and homes, performed numerous surgeries, pioneering several techniques, most notably on fistulas. His reputation as the father of obstetrics and gynecology in Egypt spread, and he lectured widely in Europe. But by the time of his death in 1974, Mahfouz had received the highest honors of the field in Egypt and abroad. He became an honorary fellow at the Royal College of Surgeons and the Royal College of Medicine in Great Britain, and he became a corresponding fellow with the New York Academy of Medicine. And as I come from New York, I show you a sculpture that's outside or of a statue. Had Mahfouz visited New York, he might have seen the statue of Dr. James Marion Sims, who some of you may know as the father of modern gynecology. Mahfouz acknowledged Sims' role in developing a cure for vesicovaginal fistulas, but probably did not know that Sims had honed his surgical skills by practicing for 4 years, 1845 to 1849, without anesthetics on 3 enslaved black women, Anarcha, Betsy, and Lucy, whom he had leased or had bought and put in a hospital started on a plantation in Alabama. Essentially, he conducted 40 operations on the 3 women until he had perfected technique. That story about these women is often left out of the story of his rise to the top of the profession. We heard he was lauded as the founder of New York's first women's hospital and of a field. So he's recently, you can see it here, in the debates that ensued the last year, the statue was actually removed off the pedestal because of the politics around Civil War statues or Civil War era statues in the United States. Mahfouz was no Sims. He has never been accused of operating on women without their consent. To the contrary, he is known to have gone out of his way for his patients, treating them with great care, respect, and sensitivity. I would like to use Mahfouz's story to consider his relationship to his patients, to restore women to the story of the origins of gynecology and obstetrics in colonial Egypt, and to sketch the history of childbirth and maternal health there. From the early 1900s through the 1960s, and Mahfouz lived even a little longer than Sahrawi. He was 92 at his death. He authored a large number of scholarly articles in Arabic and English. He wrote a history of medical education in Egypt. He wrote textbooks. He also collected specimens for teaching students about anatomy and disease, which in turn became the core of a museum. He also wrote memoirs both in English and Arabic. The fathers of modern obstetrics and gynecology, whether loving or abusive, built their careers and reputations on the backs, or better yet, the wombs of women. So I'm kind of asking, does the patient speak? Can the patient speak? I would like to start by returning to the nameless woman lying on the table in Alexandria in fall 1902. Why did she labor so long without an anesthesia and a specialist? Why were there no obstetricians in Alexandria, Egypt's second largest city, in 1902, 20 years into the British occupation? Mahfouz tells the story of his own mother's labor in his own birth in the Delta town of Mansoura in the winter of 1882. His mother, who was 45 at the time, had already bore 7 children. She labored for 3 days, attended by a doctor and a midwife. The midwife, thinking that the baby was stillborn, placed it along with the placenta on a copper tray near an open window. Half an hour later, an aunt noticed that the baby was breathing feebly. The midwife wrapped him up, cut the umbilical cord, and resuscitated him. Mahfouz was a precocious child who decided at an early age that he wanted to study at the School of Medicine. Arriving at the School of Medicine in Cairo, and this was Asr al-Aini, had been started in 1828 under Cloyd Bey, a project of Mehmet Ali. Mahfouz arrived in 1898 to begin his course of training, just as the British made English language instruction mandatory. So previous to that, the instruction had been in Arabic, but from 1898, instruction was in English. What that meant was that it led to the appointment of British instructors in place of Egyptian medical men, and the students, and particularly in certain fields, particularly in the field of obstetrics, had few lectures and no clinical training. Asr al-Aini had recently started wards for women that were superintended by English nurses, but no beds for maternity patients, no section of gynecology or obstetrics in the hospital, and no outpatient clinic. When it came to sexual and reproductive health, the only government hospitals dedicated to women were sort of so-called lock hospitals. These were specialized facilities that the British had set aside early on for female patients with venereal diseases, who were literally locked up until they were cured. British health officials in Egypt were much more concerned with infectious diseases like syphilis and gonorrhea that could spread to members of the British Army than to women's health, difficult labors, and maternal mortality, which was relatively high. In 1904, after graduation and a short stint in Suez Hospital as a medical officer, Mahfouz returned to Asr al-Aini as an anesthetist. He proposed to his former teachers that he be allowed to start a gynecology outpatient section before his work in surgery. A sample trial was set up. The British actually doubted that Egyptian men would allow Egyptian women to attend the outpatient clinic, but Mahfouz writes, the result was more encouraging than I had ever anticipated. In spite of the hesitation of the British staff, Egyptian women came in numbers. This led to the reservation of 10 beds in the hospital, with Mahfouz attached to the surgical department as an assistant and assigned all the obstetrical cases. Mahfouz points out that the number of cesarean sections was approximately 5 a year. This operation was always done as a last resort in cases of severe contraction of pelvis, admitted to hospital after fruitless attempts at delivery outside it. I say that's interesting to me because in the United States now, cesareans are at a rate of like 30 to 40%. So Mahfouz would not have approved of such a high rate. Due to the demands of the outpatient work and its success, the hospital director authorized Mahfouz to relinquish his work as an anesthetist in order to focus on obstetrics and gynecology and teaching. Mahfouz asked to go abroad to study gynecology and visit maternity hospitals, but the British director wouldn't allow him to. Instead, what he did is he brought a British expert. That's Mahfouz. Brought this British expert, Dr. Roy Dubin, who had worked in the Rotunda Hospital in Dublin, Ireland, and had read an article of Mahfouz's in the Lancet. So Dobin was, or for a long time, Mahfouz would serve as an assistant to Dobin. Since the number of hospital beds for obstetrics and gynecology was limited, Mahfouz made an arrangement with the Department of Public Health, medical officers that they call him, to attend to difficult cases in patients' homes. Over the next 15 years, he attended some 2,000 cases. He accepted no money for these cases. He was a genuine sort of scholar and doctor who wanted to learn and just keep on improving. And he tells stories of a few nights at home, most nights on the road, delivering babies. In December 1911, a couple called him in. They were so appreciative of his services in delivering a child in a hard labor that they named the child Naguib Mahfouz. So the author Naguib Mahfouz, who went on to win the Nobel Prize in Literature, was actually named after Dr. Naguib Mahfouz. At the same time, Mahfouz began performing special operations in the hospital and developing his own techniques. Okay. While elite women turned to the private care of an obstetrician or professionally trained midwife, most Egyptian women had their babies delivered by a daya or village midwife. Public health officials began to pay greater attention to these women who delivered babies when they realized that they were key to educating mothers about hygiene. And also were key to lowering extremely high rates, some 70%, a 70% infant mortality rate. Again, this was another area where the British showed little concern with bringing down infant mortality rates. But public health officials and reformers and doctors began thinking about the training and licensings of dayas and midwives. The Department of Public Health waged war on the obstetric chair, seeking to displace it with more modern positions in childbirth, but the chair remained a fixture of Egyptian births. Officials called repeatedly for the establishment of a maternity hospital and training school in Cairo. A part of the problem in training maternity cases was the dearth of beds for maternity cases, particularly in Cairo. The First World War gave Mahfouz the opportunity to begin to address this problem, and you can just see this pattern. I mean, this man worked very methodically, very slowly, very cautiously to simply transform the way medicine, maternity medicine was taught and practiced in Egypt. So during the First World War and its aftermath, Mahfouz got the opportunity to address the problem in March 1919, in the midst of the 1919 revolution, when the British director of the hospital resigned, and in the absence of Dobin, who was on leave, Mahfouz was able to push forward a scheme of finally getting a maternity ward in the hospital. They basically built it on the ground floor of what was formerly the Lady Cromer Home for Orphans. The ground floor became outpatient clinic. The first floor was a maternity ward, and the second was reserved for the foundlings. It took another 10 years to start training women doctors, when 5 female Egyptians were sent abroad for training in medicine, and 6 entered the Egyptian University Medical School. All were on government scholarships and expected to work in government jobs. And Mahfouz was very supportive of these first women doctors. They're not exactly the first women doctors in the 1840s, women were trained as doctors, but it's sort of complicated. These were the first women licensed in the way that the male doctors were being licensed. So Mahfouz finally, the hospital's really finally set up in a way that Mahfouz can begin to really perform more surgeries and cater to more women who have difficult deliveries and other gynecological problems. In 1908, to go back a bit, a woman who hailed from Upper Egypt had a prolonged labor, after which she developed a urinary fistula. So we're now turning to Mahfouz's surgery. Such a condition in which urine leaks from the bladder into the vagina, creating an awful smell and irritation, was not uncommon amongst Egyptian women in Egypt at the time. The high incidence was ascribed to prolonged labor, lasting upwards of 3 to 4 days, marriages consummated with young girls, as well as deliveries in which medical instruments tore women's tissues. And the reason why we don't hear about this so much, hear about this in Egypt today is because of Mahfouz. But the woman from Upper Egypt had 3 unsuccessful operations at the government hospital to correct the fistula, after which the surgeon advised her to go to Asr al-Aini to see Mahfouz. She basically walked from Upper Egypt. She got as far as Minya, had another operation, and then, which was also unsuccessful, and then continued to walk to Asr al-Aini, where Mahfouz, who was scheduled to go abroad finally to take his sort of tour of Europe and have the opportunity to see some of the surgeons practice and go to medical museums and so on, delayed his trip. Which also reflects on what kind of man Mahfouz was. And he delayed the trip, operated on the woman, who regained the use of her bladder. From the beginning of his career, he was interested in the academic research side of medicine. He read widely, presented papers. Presented papers at national and international conferences, and published extensively. Some of his earliest research was on cesarean section. He also maintained his interest in pioneering use of spinal stovane, and warned against the use of piturin. Mahfouz operated at Asr al-Aini, but also saw patients and operated at Kitchener's Memorial Hospital and the Coptic Hospital. So it's not enough to be a doctor, one also had to be instrumental in founding hospitals and building the institutions that the doctors could practice in. Most of his early articles were published in Al-Majalla al-Tibbiya al-Masriya. Later on, he published more extensively in the Journal of Obstetrics and Gynecology of the British Empire. Here we see just a scene from the operations. So these pictures that I show are from his atlas that I'll come back to discuss in a minute. Different things. Yeah. A few things become evident when reading through Mahfouz's accounts of surgery. One is that the women upon whom he operated were not silenced. In contrast to the slave women upon whom Sims honed his skills, Mahfouz's patients often found their voice. In 1918, Mahfouz reported on the use of spinal analgesia in a series of operations at Asr al-Aini. The stovane analgesia was greatly welcomed by our patients, he wrote in the Lancet. Most Egyptian women have a great dislike to general anesthesia. Many instances have occurred of patients refusing to have an operation done under chloroform, but agreeing to undergo the operation with stovane. Many women sought medical help because of sterility, which was sometimes caused by a cyst. In operating on simple cyst, an attempt was made to leave behind any his approach was always a kind of conservative approach. So in operating on cysts, attempt was made to leave behind any ovarian tissue that was considered healthy. While he doubted that it would cure sterility, he recognized that there was a small chance that the patient might not only that might conceive, which happened occasionally after partial ovarian resection. In some cases, actually, the patient got their way rather than Mahfouz. When operating on benign, solid, and cystic tumors, only the ovary affected was removed. We were forced to do this course since the Egyptian women value the power of procreation as second only to life. This was in spite of the fact that he would have preferred, or the doctors would have preferred, to treat all solid tumors as malignant and remove the uterus and other ovary to avoid recurrence. So in his work, Mahfouz almost always took a conservative approach. When he saw doctors in Paris performing total hysterectomies for conditions in which conservative removal of the diseased part would have been sufficient, he raised questions. In ruptured uteruses would have multiple causes. Mahfouz did not do total hysterectomies, but rather subtotal hysterectomies. And he would follow the patients afterwards to see if they gave birth. Yet it is his work. Yeah, this is either. Okay. Yet it is his work on fistulas which really stood out. Mahfouz's first publication on fistulas appeared in 1929. One of two papers read before the International Congress in Cairo in 1928, celebrating 100 years of the Asralani Hospital. He gave summaries of the operations performed, and over time, the cure rates were going up and up. This is basically his technique for the surgeons in the room. And he does talk a lot about the sutures. The women upon whom he operated were girls with faces and names, or at least initials. H.R., a well-built Sudanese girl about 12 years of age, was married 2 years ago. Menstruation has not yet appeared. 2 months after marriage, she experienced a sudden sharp pain during coitus, which was being attempted for the first time. Hemorrhage and passes of feces from the vagina followed. At the time, there was a strong push by Egyptian reformers to raise the age of marriage of girls to 16, in large part to eliminate the sorts of injuries that Mahfouz was treating. Medical evidence collected by Mahfouz and his colleagues played a role in getting the legislation passed. So this is also the social role that doctors have. Mahfouz reported that, his cure rate, towards the end of his life, he writes that the cure rate for the last 500 surgeries for fistulas was 100%. So Mahfouz gave clinical lectures to students in obstetrics and gynecology, and also lectured students in the School of Midwifery. He realized his students had no textbooks, so he actually wrote and published at his own expense 2 textbooks for the students in both medical schools and the School of Midwifery and Nursing. He also, in the course of lecturing, realized that the School of Medicine had no, the pathological museum had no specimens to help him explaining diseases to the students. So he set about preparing them. Okay, so this is the medical museum itself. He bought jars and chemical solutions from abroad. He slowly built up a collection of 300 specimens, which eventually increased to some 3,000. These were stored in the pathology department and carried to lectures. They were also exhibited during the congresses. With the support of the administration, he built up the collection, which he eventually donated to the Faculty of Medicine at Cairo University. And the collection was put in a special room, which was called Mahfouz Obstetric and Gynecological Museum. So you see some pictures from it. And that's the view from the Museum of the Nile. In building up the collection, Mahfouz was in step with the practices of the time. He had seen such museums in like the Hunterian in London. Yet the museum was, these museums could be seen as an instrument of imperial power or a spectacle of empire, projecting British authority. But the museum was also, for Mahfouz and his colleagues, a teaching tool. So this is one of these cases of adaptation and appropriation of an imperial tool. The students, staff, and foreign doctors who visited the museum clearly valued the collection. So valued were the exhibits in that in one instance, a rare specimen of ectopic pregnancy in the infundibular end of the tube from one of the surgeries was stolen by a foreign visitor. There is no mention in Mahfouz's work of patients having a voice or say in the exhibiting of tumors and other malignancies or their stillborn babies for the medical community. This is an ethical question that I'm interested in pursuing. Most of the specimens probably came from Mahfouz's poorer patients. Asr al-Aini was a public hospital, but some may have come from other clientele at the private hospitals where he practiced. In 1949, when the museum contained over 1,300 specimens, the 3 volumes of the Atlas of Mahfouz's Obstetrics and Gynecological Museum appeared to great acclaim. So this 3 volumes Atlas is this tremendous work in which he's basically a kind of textbook on gynecology and obstetrics. Mahfouz prefaced different sections with descriptions of the anatomy of the part and the pathology, and gave more extensive coverage of history, clinical features, and operation techniques. So he is competing with, or following the footsteps of Zahrawi. The catalog contained full-page drawings and paintings like the ones I had showed earlier, and photographs of specimens with short descriptions in 7 languages. Mahfouz worked closely with his grandsons, who are seen here, 2 of whom were doctors. They repaid him in a tribute of paying for the renovation of his museum, which literally, I think, within the last weeks or months, just reopened in Cairo. Wait a second. Where's the assistant? Sorry. This is supposed to... For me? I need the AV because this is supposed to play. Would you know what button I should press? Is there a button I should press here? There should be music, too. Is there sound? Okay. Is there sound? The sound is very inspirational, so you have to hear it. We have some modern heroes too, I guess. Thank you very much.
Thank you, Professor Barron. And before she finished, she said that he only died in 1974. So there are people around who remember him and were delivered by him, which is a remarkable modern hero of medicine. Our final speaker this afternoon, is Dr. Musa Muhammad Norden. He's a neonatal intensive care specialist from Malaysia, and he is going to speak about his interests and expertise in medical ethics.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Peace and blessings. Thank you very much, Anna Marie. Ladies and gentlemen, thank you very much for having me here. In particular, can I thank two individuals? First is Professor Salim Al-Hassani. I met him in July in Manchester, and he invited me to this conference. And then he put me in touch with Professor Al-Bashir. And he very quickly made the formal invitation. Thank you very much. Basically, my brief is three. One, a simple introduction. Two, I need to make mention about the organization that I'm with, i.e. the Federation of Islamic Medical Association, FIMA. And three, zoom into the area of interest of FIMA, Islamic bioethics. Yeah. Our good plastic surgeon made mention about men who remember history will make history. Actually, he adulterated the sayings of a Spanish philosopher, George Santayana, who said, those who do not remember history are condemned to repeat it. So what you guys are doing is brilliant, because you are celebrating people in history who have contributed to the welfare of mankind. And there is an authentic tradition from the Prophet Muhammad sallallahu alaihi wasallam, which says, "Khairun nas anfa'uhum linnas." The best from amongst you is those who serves humanity the best. So we are celebrating some of the best who have preceded us, and we hope we can emulate some of their characteristics, their inquisitiveness, their passion for new knowledge, science, new skills, and writings. Yeah. FIMA, the Federation of Islamic Medical Association, in one of its domain of interest is looking at the ethics of medicine. In fact, when I did my small research, probably the first person who engaged vis-a-vis the ethics of the physician was Ishaq bin Ar-Rahawi. I pronounce it right, yeah? Yeah? He from 854 until 931. And he wrote a text called Adab al-Tabib. Adab al-Tabib, yeah? Which is the conduct of the physician. Brilliant, yeah? And in fact, because of his works, the Caliph al-Muqtadir in 931 made it compulsory for every physician in the land to be licensed before he can practice medicine. Yeah? That is accreditation, credentialing, because the Caliph found out that one of his citizens died because of the negligence of a physician. And probably the closest to Ar-Rahawi that I can think about, and it's very close to you guys in Fez, is Maimonides. You can see his bust out there. He was trained, he came 300 years later, he was trained in Cordoba, and I believe he still has a house in Fez. Wallahu alam. So, this is my second brief. FIMA. we are about 37 years old, right? And I have actually known virtually all of the founders. They are my mentors, my teachers. This guy here, Al-Marhum, Sheikh, a cardiothoracic surgeon, Ahmad Al-Qadi. He started it with this guy right here, Professor Said Mubin. He's a psychiatrist from Pakistan. And to his left is Hussein from South Africa, a urologist. They came together in Florida in 1981 and started FEMA. That was the vision of our predecessors. Amazing. Yeah? And the aim being to foster unity between the healthcare professionals. Yeah? To bring our science together, our hearts together. Promote healthcare services, education, and research. And to mainstream the ethics of Islam in medicine. Yeah? And mobilize our manpower for the welfare of humanitarian relief. I'll show you some examples very quickly. And then very importantly, like what we are doing now, I'm doing now is to collaborate with you guys in this aspect of rahmatan lil alamin. Mercy for mankind. Mercy and healing. Shifa, healing for all mankind. So our members from 50 countries, from Australia in the east to the United States of America in the west. Morocco was a member. In fact, I was in Marrakesh in 2009 when we held our conference there with the Islamic Medical Association of North America. By the way, Dr. Sharif is the president of BIMA, Britain Islamic Medical Association. This is the exco for the next 2 years. You see, it's a mixed bag. This guy on the left sitting down is a public health expert from Jordan, and this guy is a cardiologist from Malaysia. This guy is a radiologist from Pakistan. Parvez is a plastic surgeon. Ataullah is an endocrinologist, a public health guy, and, well, I've never grown up. I'm a pediatrician. Right, so there you are. This is the international networking that we have from the United Nations since 2005, the World Health Organization, the Organization of Islamic Countries, and all of these humanitarian bodies. And we hope, inshallah, we've made the next link with you guys here in Fes. Your work with the heritage is wonderful. Yeah, it's awesome. This is the relief work that we've done, humanitarian relief, bringing healing, shifa to humanity from Bosnia in 1992, Chechnya 99, Kosovo 99, Afghanistan 2001 when it was bombed, the earthquake in 2003. I was in Kashmir in 2006 during the earthquake. This is an overland journey we made from London across Europe to Turkey, and then we were in Latakia in Syria, where we were stuck for 3 weeks because we were negotiating with Mubarak to go across to Palestine, to go across to Gaza. Right? There were about 300 volunteers, 150 big trucks with 6 million USD worth of educational material and food stuff. Yeah. And we, the Malaysians, we drove, you can see there were six trucks there. And that's Indonesia, 2009, and this extends to humanity. And we were in Haiti in 2010, we were in Puerto Rico recently. That's Pakistan, Libya, Somalia, Gaza. You know, Gaza in 2014 when it was bombed again by the Israeli occupying forces. Yeah, in 2014, we in FEMA were the first team to come in with the humanitarian relief. Yeah, that's Syria, Malaysia. We had floods then, and now as I'm speaking, our boys are in Palu, Sulawesi, to deal with the victims of the earthquake and tsunami. This is some of our projects. FEMA Safe Vision, probably the largest as far as eye is concerned. 20 countries, we were in 20 countries, in about 600 eye camps. We've seen 2 million patients, and we've done 200,000 cataract surgeries. You made mention about cataract surgery by Az-Zahrawi. We've done, this is Az-Zahrawi in the field, in the camps, yeah? And for this, we were awarded by the American College of Physicians. A bit strange because we're a Muslim body, awarded by American College, and the award is actually a Jewish award, Linda Rosenthal Award. And this is Fima Say Smile. You know, you are a plastic surgeon, reconstructive surgeon, very delicate work, but we can do it out in the open. Look at this guy here, such a handsome boy after the surgery. We've been in 6 countries, done about 2,000 of this. Yeah, this is even more problematic. You talk about the obstructive labor, yeah, and how it created recto-vaginal fistula and vesico-vaginal fistula. They were passing urine from the vagina, stools, feces from vagina, and because of obstructed labor, poor OBGYN practices. And we've done, involved 88 surgeons, done about 30 camps, about 2,000 patients now, yeah, and the success rate out in the open is 85%. Yeah, so there you are. So we make an investment in students. I just had a chat yesterday with the students from Al-Bashir students. Yeah, about 50 of them came, investing in the young. Yeah, our inheritors. Yeah. So you see, we've had camps in Abaha in Saudi in 2001, right? In Tripoli 2004, Egypt 2005. This was the first camp that we held in Malaysia in 2005, and we had girls and boys together, right? And this is in Indonesia, and then we were in Langkawi again in Malaysia. My daughter was a student then, and she handled the camp with her 16 friends, right? I was just there to oversee and just give some content. They did it by themselves. Students trained, yeah, with the skills, yeah. By the way, she's now a pediatrician herself. This is in Egypt, and then we also have this Umrah camp. We train our students in Mecca and Madinah al-Munawwarah. And again, we have a consortium of Islamic hospitals and medical colleges. And this brings me to the ethics beat. You may say it's an obsession to make sure we do things right. Right? We do things right. As is expected of the Quran, traditions of the Prophet, and the jurisprudence of the fuqaha, of the religious scholars. And we have this journal, the International Journal of Human and Health Sciences. You can get this online. We've already published 4 within a space of 4 journals within a space of 6 months, and it's indexed by Google Scholar, Crossref, and Index Copernicus. The next step is PubMed, inshallah. And this is the yearbook that Al-Bashir wanted me to specifically talk about, yearbook FEMA. Right? We've had it since 1996. The topic that he wanted me to talk about was yearbook 2016. This is very quickly looking at the yearbooks over 16 years, yeah, all the topics. And this is 2016, right? It's actually part 3 of our Encyclopedia of Islamic Medical Ethics, and this one was focused on medical care at the end of life. An extremely sensitive subject, very difficult, all right? It's a time bomb, but we need to deal with it, yeah? And the starting point is, again, the priorities of the Islamic jurisprudence, maqasid shar'iyah, in the context of Islam. These are principles that we have to adhere to very, very carefully, yeah? In a situation of difficulty, it is always important for us to prioritize ourselves, i.e., we need to preserve morality, and religion. And look, this is where we come into place. As surgeons, as physicians, we need to preserve life. And this is base, and this is what inspires us. It is a verse from the Quran in Surah Al-Ma'idah, وَمَنْ أَحْيَاهَا فَكَإِنَّمَا أَحْيَا النَّاسَ جَمِيعًا. It's inspirational. You save one life, it is as though you save the whole of humanity. This keeps us going despite all the difficulties, all the odds. And to preserve progeny, intellect, this has all got to do with our medicine. But indirectly, it also involves poverty, because medicine is expensive. But our budget is finite. But the problems are infinite. So it involves being very prudent with our spendings. Yeah? And of course, we are also guided by the Prophet's prayer where we talk about end-of-life issues, whereby he said, "Oh Allah, please let me live if that is for my good, and please let me die if that is better for me." I.e., the one who decides is not us, but it's God, Allah subhanahu wa ta'ala. So, when we talk about end-of-life issues, these are really painful, difficult dilemmas, not just for us as physicians, but for the patients, for the family. Yeah? How much should we allow our loved ones, our patients, to suffer? Should we do everything that's under the sun to keep them alive, even though the long-term prognosis is poor? Should we allow the ventilator, other life support modalities, cardiac drugs, right? Inotropic support, yeah? Or should they be discontinued upon our advice or upon the request of the patients and their families? And should we consent to DNR, do not resuscitate? These are advanced directives either from the patient prior to him or her getting into coma, or from the family members. And an equally important priority is how much longer can we afford? I mean, it becomes a financial catastrophe for some families. Yeah. So we actually dealt with these very difficult issues in our yearbook 2002. Right? You can see this. We talked about aging, we talked about the living will, we talked about brain death, end-of-life issues, the right to die, euthanasia. But because of new technology, new science, we can prolong life. But that equate with quality of life, QOL, the art of living. Right? So very quickly, if I may summarize what's in the yearbook, we looked very quickly at the 3 P's of aging: physiology, psychology, and the politics of aging. All right? If you look at the global life expectancy in 2015, it was 71.4 years, ranging from 60 years in Africa to 77 years in Europe. And yes, at the same time, talking about the politics of aging, we need to realize that this geriatric population still have contributions to our human society in terms of their skill sets, in terms of their experience, in terms of their wisdom. There is still an investment in the society. And it is with this that we can frame what's called a holistic program for end-of-life care and the peculiar challenges that comes with it. So there are certain ground rules that is extremely important that we have to adhere to. Very important when we talk about Islamic ethics within the context of the issues of end of life. Allah says that there is a tradition from the Prophet ﷺ that says there is no disease that Allah has created except that He also has created a remedy. So that is an instruction to the Muslims to research, to find for remedies, to treat, yeah, and to eliminate diseases. So the scholars say that if a medical intervention is found to be effective, found to be safe, and it correlates with good recovery, cure, then they opine that it is mandatory to undertake the treatment. Wajib. However, other forms of treatment, the default rule is optional, i.e. not mandatory. In fact, some scholars would say otherwise. It is sunnah, while even fewer scholars would say that it is wajib. So these are ground rules we need to know. So if the chances of a cure or recovery from an illness, a critical illness, a cancer, a myocardial infarct, a stroke, is virtually nil, there is therefore no religious rationale for ruling that it is wajib, i.e. you must do everything under the sun to save this guy, even though he's got a cerebral hemorrhage there and he is in a vegetative state. So extremely important for us to recognize this. Therefore, not beginning to use a respirator or choosing to discontinue the ventilator or not choosing to intubate or choosing to extubate is simply choosing not to operationalize the optional rulings. Very important. Sorry, it's a bit busy, but it's extremely important. The physician cannot be penalized if he chooses not to intubate to a man that is brain dead. Right? Nor should he feel any guilt when he does not choose to operationalize an action that is optional, that is ikhtiyar. However, we need to always remember that preservation of life is a priority of maqasid sharia, the priorities of the sharia. So we should always endeavor our very best to preserve life. However, when a cure or recovery is not a realistic expectation, or the treatment options are an exercise in what we call medical futility, no benefit whatsoever, no maslahah, or the treatment entails extreme measure, right? Then we may opt to withdraw or withhold such treatment modalities, and we should counsel the patient and the family accordingly. Patient is on the ventilator, brain death. I mean, the physician needs to tell the family. It's difficult, but you have to tell. His brain is dead. So you need to consider extubating, remove the patient off the ventilator and see what happens. And of course, it will be death eventually. But at the same time, despite doing this, so what I'm saying is that no heroic measures, yeah? But at the same time, we make sure that the patients continue to enjoy appropriate medical and nursing care. The best medical and nursing care. Not compromise. TLC. Tender, loving care. Maintain their fluid and nutritional requirements. That's why in the case in the United States of, what's the name? Chauvet, where vegetative state, right? The husband wanted to stop the IV line, wanted to stop the feeding, while the parents said no. Went to the court, ding dong, finally the husband won. They removed the feeding tube, they removed the IV line, and Terry Chavo died. Died from basically dehydration and malnutrition. That is not right from the perspective of Islam. You still need to maintain your fluids, nutritional requirement, and provide optimal pain relief. Use of opioids, yeah? Encourage hospice care of the terminally ill. So in that case, I could not understand why that lady was in the hospital and using valuable resources. It would have been more humane for Terry Chavo to be in her house, in her room, with her family, fed by the father or the mother with the feeding tube, and to die peacefully in her home ambience. Yeah? That would have been more humane. Yeah? So our palliative care for the terminal ill must be holistic, caring for not just the physical, but the psychological, social, spiritual well-being for the patient, as well as the family members. It's also very important for us when we deal with the youngest, the oldest, the geriatrics, and the critically ill. We check with the patient or the immediate relatives whether there were any advanced medical directives. Example, no DNR. If I have a myocardial infarct, no resuscitation, no intubation, no ventilation. You have to ask this, and you have to document this. That stipulate the patient's choice of medical care or intervention should he lose his mind, become demented, or enter a stage of coma when he cannot then make any decisions. So it's also important from the Islamic perspective, apart from the physical healing, we must manifest our empathy by comforting our patient, encouraging them to beseech healing, shifa, patience, sabr, perseverance, istiqamah, and rahmah from Allah subhanahu wa ta'ala. Euthanasia, which is licensed first, I think, in Netherlands and now in a few countries in the world, is categorically prohibited, haram in Islam. Okay? And we also encourage our patients the practice of talqeen to remind themselves, because our living is a continuum from here to the hereafter. So always reminding them in their critical end-of-life moments of the remembrance of Allah subhanahu wa ta'ala. So those were the 16 chapters that I tried to summarize here. This, by the way, is our 2017 yearbook, Encyclopedia of Islamic Medical Ethics, Scientific Biomedical Research, the Islamic perspective of research. Yeah, we've done this. I wrote the editorial for this. I'm leaving copies for Al-Bashir and for some of your medical faculties in I think you got 6 medical schools. I think I have enough for each of your medical school in Morocco. All right, and next 2018, yeah, we hope we would come out on the bioethics of reproduction, from contraception to sterilization to IVF, surrogacy, semen, over, embryo banks and donation, posthumous impregnation, adoption, beginning of life, right down to fetal sex selection, which Dr. Sharif has volunteered, and PIG, pre-implantation genetic diagnosis. So if you're very keen to contribute to our yearbook, these are some information that will be very useful. That's my email address. You can text me, or you can Google. All of our books are online. All right, it's free information. FEMAweb.net. Thank you very much for your kind patience.
My question actually is for Hamza, for Musa, and it's very important. The debate of the ethics is taking place in the West, but perhaps less in the East. What do you think? I mean, you've summarized a good number of the cases in there, and you've asked for guidance. Do you have a way of leading the jurisprudent experts to understand the dilemmas and the intricacies of what the physicians and the doctors or the medical professionals are facing. So you can perhaps simplify it or show them the details and say, well, we need a legal way from religious point of view rather than leaving the medical profession alone in this dilemma.
Thank you very much, Dr. Gumati. Muslims have never had issues with bioethics because there was never a separation between the spiritual and the mundane life. And that's why when Ruhawi first introduced the tabib, adab al-tabib, it was natural. You know, they were already practicing it. And similarly with the Judaism theology, right? That's why Maimonides, who is a rabbi, a scholar as well, right? He came up with his principles of ethics in medicine somewhere around 1100s. Yeah. The problem with Enlightenment or Renaissance was that there was this separation between, or secularization between what is spiritual and what is personal and what is state affairs. And that is that break, that divorce. And that's why the modern world only knew about ethics or addressed the issue of ethics after the 1940s, after what the Nazi Germans did to patients in the war camps, yeah? After what the Americans did to the Negroes, did to the prisoners, you know, they jabbed them with syphilis bacteria to find out the effects of syphilitic meningitis. This had to be addressed. And then Buchem and colleagues came up with the 4 tenets of autonomy, maleficence, beneficence, and justice. Something that was already being practiced by the Muslims physicians, not just ethicists, Muslim physicians. Wallahu alam.
That it's very lucid, this deliberation by Dr. Musa. The problem which arises from here and what delivered here, there is a gap in between the development of history of medical ethics in medical science. As you described that these principles of ethics, beneficence, non-maleficence, justice, and all that, it is started from the Hippocratic Oath itself. There is. But what happened after these Nazis experiment or that, we directly jumped to the Helsinki Declaration. In between the Helsinki Declaration and between this Greek and Arabs physician, there is no history at all on record. This is the main vacuum which should be fulfilled in the history of development of medical ethics.
Yeah, it's very right, because one of the principles that was anointed by Hippocrates is primum de nocere.
All 4 principles are there in the Hippocratic
That is on maleficence. Primum non nocere. So just a little bit Latin. First, do no harm. Right? And if you go to history, there was not actually a void. That's what I emphasize to you, that Isha al-Ruhawi rejuvenated this concept of the ethics of the physician. Adab al-Tabib. Yeah? And then which was further taken into more detail by Maimonides. But as far as the new civilization was concerned, Renaissance, there was definitely a huge void. Yeah? Wallahu alam.
This will have to be our final question.
Thanks very much. I just want to make a quick comment. Yeah, back to the bioethics, not only for the physician-patient relationship. I think we're having a bit of dilemma nowadays. I'll just bring a little example of what's happening in the West. For example, in England, in Britain, Now, the organ donation issue, for example, now we are going into the opt-out technique. I don't know if you're aware. The opt-out means everybody is considered to be organ donation till he or she said otherwise. And I think this is where we need to get into some sort of good conclusion. I know there's a lot of work being done by Minister of Health in Britain, and they're trying to get like multi-phase to be in a group and to find a way to encourage this. There's a plenty of issue anyway in different culture. Probably maybe nothing to do with the religion itself. It's a cultural issue, I'm afraid. And this is really affecting what's labeled as religion or as a cultural issue. Again, I think in the Muslim community, normally it's done by institution rather than just by individual scholars, because you need a group, committee, majma' fiqhi, to have to be supported by the medical side as well as the people who knows the rulings. To make
so with this opt-out option in organ donation, you are a donor unless you specifically sign the form saying, no, my organs are not for donation. This is already being practiced in Singapore. Now, I think this goes bang against the first concept of bioethics, i.e. autonomy. Yeah? I.e. the right of the person to determine what happens to his or her kidneys or heart. Yeah? So, at the end of the day, we also need to consider another principle whereby you need to consider the good of the maximum benefit for the society compared to the person. This is a concept of utilitarianism. So you have to balance that. But and that is something that the nation has to discuss within the context of the different cultures that you have. Wallahu a'lam.
Friends and colleagues, we're right off time. Thank you very much, and thank you again to our speakers.
Thank you very much. Licensed in Louisiana as a charitable organization. Yeah, we would not have we've been there since 1981. We have navigated this difficult issue.
No females in your.
Oh, there is.
I was going to say.
There is.
There is? No picture of them. No proof. Okay?
Yeah.
Nice talk. It explains why the Egyptians are very good at institutions. They are. I'm a Sudanese, I'm a radiologist. Is the Baron Arabic name? It sounds like it. Yeah. But the Egyptians are very good at institutions all over the world. And I think maybe that goes back to them. Yeah.